Doctor, you may begin. Dr. Kaleem, you may commence the session.
Okay. Assalamu alaikum. So, Pakistan Endocrine Society has the legacy of transforming scientific knowledge to the health professionals across the board. To continue this mission, today we are here to present interesting yet very important talks on the hyperglycemia management in hospitalized patients who are critically or non-critically ill. So for this, we have esteemed speakers as well as distinguished panelists. Before we commence the session, let me introduce our today's speakers. So our first speaker is a founding member of Pakistan Endocrine Society and current executive member of Pakistan Endocrine Society. Very passionate speaker who has insight on the topic, Dr. Zakir Alvi, who is a consultant endocrinologist at South City Hospital, Karachi, as well as Medicare Hospital, Karachi. So Dr. Alvi will talk about the hyperglycemia management in non-critically ill patients who are hospitalized. Our second worthy speaker is again executive member of Pakistan Endocrine Society. He has remained former General Secretary of Pakistan Endocrine Society and is a consultant endocrinologist at Shifa International Hospital, Islamabad. Please welcome Dr. Usama Ishtiaq. And today, Dr. Ishtiaq will talk on hyperglycemia management in the critically ill patients who are hospitalized. Before we carry forward this session, I'll take this opportunity to introduce our worthy and distinguished panelists. We have here the President of Pakistan Endocrine Society, a consultant endocrinologist at Aga Khan University Hospital, Karachi, Dr. Aisha Sheikh, who has contribution in the field of the endocrinology by her publications as well as work. Along with Dr. Aisha Sheikh, accompanying her today, we have the Vice President of Pakistan Endocrine Society Sindh chapter, Dr. Azra Rizwan. Dr. Azra Rizwan is a consultant endocrinologist in Aga Khan University Hospital, Karachi. And again, she has a passionate and insight work in the field of the endocrinology. So on the behalf of this forum, I would warmly welcome our distinguished panelists as well as esteemed speakers and all those who have joined our webinar today. I'd like to request Dr. Alvi to please start his session.
Assalamu alaikum. I hope everybody can hear me. And so I'm not going to waste much time because we want to leave enough time for question and answer afterwards. I'm going to start by sharing my slides. And there we go. So can everybody see my slides? Dr. Kaleem, मेरी slides नजर आ रही हैं?
Yes, sir, they are visible.
Okay, great. So I'll start. Thank you very much for asking me to do this talk here today. Thank you to Pakistan Endocrine Society and especially to Dr. Azra Rizwan for inviting me. The topic I'm going to talk about is something we often see, however, unfortunately, it's not usually managed as well as should be. It's a common problem is hyperglycemia in non-critical setting. if not managed right, what we don't realize, especially in the non-medical wards, is that it often goes unattended and not enough attention is paid to it. It can have harmful consequences, often does have harmful consequences, and occasionally may have disastrous consequences. On the flip side, managing it right and managing the hyperglycemia right has tremendous benefits in patient recovery, management of illness, and good outcomes. So I'm going to confine my talk to the management of hyperglycemia in the non-critical setting. So obviously, there's a little bit of overlap here and there. So I'm going to stick to the non-critical setting and leave out bits for Dr. Osama to talk about the critical settings. The prevalence of diabetes is increasing globally, as we know. Currently, 537 million people worldwide, of which 33 million people in Pakistan are suffering from diabetes. Spending on diabetes on a global proportion, GDP, it is projected that the spending currently is 1.8% of global GDP, and it will increase to 2.2% by 2030 of the global GDP. We don't have many numbers for Pakistan, but for the US, for example, 24% of total healthcare spending is because of diabetes and hyperglycemia. Almost 70 billion a year is spent on inpatient hyperglycemia in the US. So suggesting that almost 1/5 of the budget for inpatients spent on hyperglycemia alone, and similar numbers, you can see similar proportions would be spent in Pakistan as well. We don't have numbers, but I would presume. And that's the budgetary expenditure. Patients with diabetes have 4 times greater risk of hospitalization with longer hospital stays and a greater chance of readmission compared to patients without diabetes. People with diabetes have a 35% greater chance of elective surgeries, any elective surgeries in general. So they're hospitalized more often. So we'll just quickly go through the pathophysiology of hyperglycemia in the sick patient. So in the fasting state, normally blood glucose is maintained very accurately between 70 and 100, and is finely regulated between utilization of glucose and production by the liver. The stress of acute illness and surgery in hospitalized patients increases the production of counter-regulatory hormones and pro-inflammatory cytokines. These being cortisol, glucagon, growth hormone, TNF-alpha, interleukin-6, interleukin-1 beta. These are a few examples of the cytokines. These are pro-inflammatory. This leads to increase in hepatic gluconeogenesis, increase in muscle catabolism, and lipolysis. These changes can induce acute hyperglycemia in hospitalized patients with or without prior history of diabetes. So there's this term called stress hyperglycemia. So hyperglycemia, which is blood glucose more than 140 in a hospitalized patient without a history of diabetes in the past, is defined as stress hyperglycemia. And it is reported that 32.2% of critically ill patients and ICUs and 30% of non-critically ill hospitalized patients suffer from it. Of these, 60% of these will go on to develop diabetes in a year after the hospital admission. So perhaps there is an element of somebody's tendency towards hyperglycemia, and they seem to be at risk of developing stress hyperglycemia more often than others. Stress hyperglycemia in patients without diabetes can be seen in the first postoperative day and may persist for 9 to 21 days following surgery. So how do we differentiate between stress-induced hyperglycemia and pre-existing diabetes? To differentiate undiagnosed diabetes versus stress-induced hyperglycemia in the hospitalized patient, guidelines suggest that you do a measurement of HbA1c on admission. In the presence of a fasting blood glucose of more than 40 or 140 and A1c of more than 6.5% confirm the diagnosis of pre-existing diabetes. Several studies, and I have them down here, since 2015, 2017, have shown that hyperglycemia with or without diabetes has been associated with increased mortality, morbidity, in hospitalized patients. So therefore, insulin therapy was recommended for the management of hyperglycemia in the hospitalized patient. However, studies have also shown that tight glucose control can be associated with an increased risk of insulin-induced hypoglycemia, and which in turn has an increased mortality in the hospitalized patient. So that's the flip side of it. Accordingly, glycemic targets have been revised by the professional organizations to avoid tight or intensive glycemic control in the hospitalized patient. Looking at hyperglycemia and the hospitalization outcomes, see what happens is hyperglycemia alters immune responses by inhibiting chemotaxis and phagocytosis. It affects the bactericidal ability of the immune cells, and by decreasing the production of superoxide, it induces osmotic diuresis, endothelial injury, mitochondrial dysfunction, and all these can go on to cause shock and multiple organ failures in the hospitalized patients. In the hospitalized patients, hyperglycemia is associated with an increased risk of complications, higher mortality, higher rate of admission to ICU, and the need of rehabilitation after discharge. It has been reported that the risk of post-operative infection in general surgery patients increases by 30% for every 40 milligrams of sugar rising above normal glycemia. That's a massive. In a study of surgical patients with glucose levels of 110 to 200, which means somewhat elevated, and glucose levels above 200, they had a 1.7 or 2.1 fold increase respectively in mortality compared to patients with blood glucose less than 110. So even mildly elevated hyperglycemia of 110 to 200 can increase a mortality risk. In a prospective study of patients with community-acquired pneumonia, so now this we're looking at the medical ward patients, with admission blood glucose above 198 milligram per deciliter, which is 11 millimoles, the risk of complications in these patients increased by 3% for every 1 millimole or 18 milligrams rise in admission blood glucose above 110. So for every 18 milligram above 110, your risk increases by 3%. Many other studies have suggested that the early intervention and treatment of inpatient hyperglycemia can reduce the risk of hospital-acquired infection and decrease the length of hospital stays and mortality. In a recent analysis, well, not so recent, it's from 2018, on surgical patients showed that tight blood glucose control as compared to conventional control of less than 200 was associated with a lower post-operative infection, 9.4 versus 15.8%, lower wound infection rates, 4.6 versus 7.2%, but a higher post-operative hypoglycemia rates. However, the short-term mortality was not significantly different in both groups. So therefore, it was suggested कि जब lower risk of post-operative infection हो रहा है, lower wound infection हो रहा है, lower complications हो रही हैं, yet mortality is not different. So it is thought that the higher risk of hypoglycemia events in the tight glucose group contributed to the mortality rate in that group. So hypoglycemia and hospitalization outcomes के क्या effect है? Hypoglycemia in the hospitalized patients is categorized through 3 levels by the ADA. Level 1 is defined as the blood glucose of between 54 and 70. Level 2 is less than 54, 54 milligram being the neuroglycopenic threshold. And level 3 is any blood glucose level with an altered mental or physical status that requires assistance from others for recovery. Hypoglycemia in the hospitalized patient is associated with poor cardiovascular outcomes, including prolonged QT interval, angina, ischemic changes, arrhythmias, and even sudden death. Hypoglycemia is associated with increased level of pro-inflammatory cytokines as well. TNF-alpha, interleukin-1 beta, interleukin-6, interleukin-8. Markers of lipid peroxidation and oxidative stress. These changes contribute to the adverse cardiovascular events associated with hypoglycemia. In 2019, a systemic review suggested that hospitalized patients on the general medical surgical wards with an episode of blood glucose less than 72 milligrams had a higher in-hospital mortality than patients without hypoglycemia. the incidence of severe hypoglycemia less than 40 in ICU patients has been reported in 28% of the patients, and in the non-ICU setting as high as 33%. The risk of hypoglycemia events increases in hospitalized patients with older age group, use of oral hypoglycemic medication, presence of severe illness, unexpected changes in nutritional intake, and steroid tapering. These are the risk factors of hypoglycemia. In non-critically ill medical and surgical patients, the ADA and AACE recommend a target of pre-meal blood glucose lower than 140 and random blood glucose lower than 180. Subcutaneous insulin is suggested as the treatment of choice for non-critically ill patients. However, the use of sliding scale insulin alone for hospitalized patients with diabetes is not recommended. For hospitalized patients with type 1 diabetes, the use of basal insulin plus short or rapid-acting insulin for meal coverage is recommended. Recent studies have reported that the use of subcutaneous basal insulin plus short or rapid-acting insulin prior to meals, which is called the bolus, is the most appropriate and safe treatment for management of hyperglycemia in hospitalized patients with type 2 diabetes. So, trials and studies come out often and increase to our knowledge all the time. However, there are certain trials which cause a change in practice. So I'm going to talk about a couple of trials which are called practice-changing trials. These led to a change in hospitalized patients' management of hyperglycemia. So one of them is RABBIT-2 medicine. So in this prospective randomized multi-center trial, RABBIT stands for randomized study of basal bolus insulin therapy in medical patients. 130 patients with type 2 diabetes were assigned randomly to basal bolus insulin regimes versus sliding scale. This study showed that 66% of patients in the basal bolus regime group achieved a blood glucose less than 140, compared to 38% only of patients with sliding scale. The incidence of hypoglycemia was the same in both the groups. So they next went on and did the similar study in surgical patients called the RABBIT-2 surgery. So in 212 patients, surgical wards, either sliding scale insulin or basal bolus insulin. In this study, blood glucose lower than 140 milligrams was achieved in 55% of patients with basal bolus insulin and 31% of patients in the sliding scale group. The rate of complications such as wound infection, pneumonia, acute kidney injury, and acute respiratory failure was reduced in the basal bolus insulin regime group versus the sliding scale, 8.6% versus 24%. So big reduction in complications. However, hypoglycemia with blood glucose lower than 70 milligrams was seen in 23% of patients with the basal bolus group versus 4.7% in patients with the sliding scale group. So something was very different in the surgical ward compared to the medical ward. This led to another trial called the Basal Plus trial. So due to the high risk of hypoglycemia in the basal bolus group in the RABBIT-2 surgical, subsequent study was done in which they compared basal insulin plus a lower correctional scale only. So basal and usko pe correctional scale dete rahe beech mein. No fixed boluses. Versus basal bolus typical versus sliding scale regime. So 3 arms bana diye. In insulin naive patients who were on oral agents at home and were well controlled, less than 180 ghar pe rehti thi sugar, or in patients with minimal insulin usage at home, which was less than 0.4 units per kilogram, and in patients with poor oral intake in the hospital. So these are the kind of patients which are at a higher risk of hypoglycemia. So give a higher risk of hypoglycemia patients leke uske andar unne ka 3 protocol dete hain. Ek, number 1, basal bolus. Number 2, basal plus only correctional dose and a sliding scale. So what happened was that in the basal bolus and basal plus group, both had less treatment failure than sliding scale. So 0% versus 2% versus 19% treatment failure in the sliding scale. The incidence of hypoglycemia with blood glucose lower than 70 was higher in both basal bolus and basal plus, but the basal plus was slightly less than basal bolus, though it was not statistically significant. 16 versus 8% looks significant, but wasn't. Then the sliding scale had only 3%. However, the incidence of severe hypoglycemia with blood glucose lower than 40 milligrams was not significantly different among the three treatment groups. 1%, 1% for bolus, basal bolus, and bolus basal plus, and 0% for sliding scale. Therefore, for surgical patients with poor nutritional intake or at a high risk of hypoglycemia and patients with low dose insulin at home, it is recommended to use basal insulin plus correctional scale with short-acting insulin rather than using meal boluses or sliding scale. So, correctional dose de denge, that means when you check the sugars and the sugars are higher than target, you just give enough insulin to correct that sugar to bring it down to target. You're not giving a bolus to cover the meal. That's the difference between basal bolus and correctional with basal, or called basal plus. So, in summary, these practice-changing trials showed rabbit 1 medicine showed target less than 140 fasting and less than 180 random, and the use of basal bolus regime over sliding scale. Rabbit 2 surgery showed same numbers should be targeted and recommended the use of basal bolus regime over sliding scale. Basal plus trial recommends the use of basal plus correctional scale in surgical patients with a higher risk of hypoglycemia. The insulin dose, recommended insulin dose for most patients with type 2 diabetes admitted to hospital is 0.3 to 0.5 units per kilogram. However, the starting dose in elderly patients and in patients with impaired renal function should be lower because they have a higher risk of hypoglycemia. So, targets in non-ICU, including pre and post, well, it's the same. ADA or endocrine society is 140, less than 140 pre-meals or fasting, and less than 180 after random. However, endocrine society adds that for terminally ill patient with low life expectancy, it should be less than 200. So, insulin therapy in non-ICU patients, kya karenge? This is the kind of chart you will see in most of the studies and papers and recommendations. It looks very complicated, but it's very simple. Basically, जब patient आता है तो आपने 3 में decide करना है, उसको divide करना है. Number 1, is this patient usual insulin requirement वाला patient है, या insulin sensitive ज़्यादा तो नहीं है, which is people who have reduced kidney function, a GFR less than 45 or age more than 70. These people are very insulin sensitive. Or is this patient more than usual insulin requirement, which means who have insulin resistance, either they are on steroids or a BMI of more than 35. ये 3 ग्रुप में डिवाइड करके we differentiate the dose of the basal insulin, which is very simple. कि भाई sensitive group ज़्यादा है तो 0.1 to 0.15, 0.15 तक आपने उसका basal per units per kilogram body weight आपने उसका basal dose लेना है. Usual insulin requirement है 0.2 से 0.25 units per kilogram, and insulin resistant patient है 0.3 units per kilogram would be the basal insulin. अब इसके अंदर अगर patient has got a poor intake or is nil by mouth, you add only a correctional scale insulin. If this patient, and all 3 groups, right? So all 3 groups is same है, तो correctional scale insulin खाली add करना है. Normal intake है patient का, so you go basal plus meal bolus insulin and correctional scale. So meal bolus, and अगर प्री मील आपका टारगेट से ऊपर है उसको करेक्शनल उसके ऊपर ऐड कर देना है. And same thing in all 3 groups of patients. And if the patient is on a low dose insulin at home, then it's plus you can give them just basal insulin, and you can add a DPP-4 inhibitor, which is safe in all 3 kind of patients. But this is only on patients who have been consistently less than 180 blood sugar prior to admission on a low dose insulin. तो ये वो ग्रुप ऑफ पेशेंट्स के अंदर सिर्फ हम कह रहे हैं कि आप बेसल इंसुलिन अकेला दे सकते हैं और उसके साथ DPP-4 इनहिबिटर ऐड कर सकते हैं, which is safe and effective. So when you talk about steroid-induced hyperglycemia in the hospitalized patient, the use of steroids in hospital setting is very common. In the West, the most common form of administration is the daily morning use of prednisolone, which usually results in hyperglycemia in the late afternoon and in the evening. In Pakistan, this might be different. Actually, it is. It is uncommon for a single morning dose of steroids to be given. hours setting is usually twice daily steroids by mouth. I'm talking about, this is non-critical patient, or even 3 times. हम prednisolone with 3 में divide करके देते हैं या 2 में divide करके commonly. That's the common practice in Pakistan. So in which case the hyperglycemia is not only just late afternoon and evening, it can be all around the day. So the goal of treatment in insulin, so let's say patients who are getting once daily steroids in the morning, the insulin treatment goal is to avoid daytime hyperglycemia. वैसे भी steroid से the main rise in sugar is in the postprandial part, and fasting में कम असर होता है relatively. So therefore the use of basal insulin NPH, can I NPH दे दें basal के साथ with a morning dose of prednisolone is recommended to, in addition to patient's daily basal bolus. So उसके जो भी basal bolus हमने decide करा हुआ है उसको देने के लिए कि ये basal dose है और इतना bolus है, उसके लिए वो तो देना है, morning dose का NPH दे देंगे, तो उससे वो day time rise जो आ रहा है या शाम तक का rise जो है वो cover हो जाता है. For longer acting steroids such as dexamethasone, or as we are using steroids around the clock, then we use basal analog insulin with bolus as suggested. Pre-op क्या करना चाहिए? Well, you hold metformin, don't give sulfonylureas, stop TZDs. This is prior to coming in for admission for surgery. Hold SGLT2 at least 3 or 4 days prior to surgery. However, you may continue metformin DPP4 inhibitors on the day of minimally invasive surgery. Minimally invasive short surgery, short patient stay, वो अपना usual metformin DPP4 लेके आ सकता है, छोटी surgery उसकी हो गई local में, या even short GA surgical procedure, and then they can go home. So that's safe. If the patient has normal intake and on insulin, so you hold the short-acting insulin on the day of the surgery. Use only 80% of the glargine insulin on the day of surgery. Short-acting देनी ही नहीं है, glargine में सिर्फ 80%. And if they are on 70-30 insulin, and if the blood glucose is more than 120, you give them 50% of their morning dose. And if the blood glucose is less than 120, you don't give them the morning dose. However, you have taken a history of the patient. You have asked the patient's patterns. You have seen his level or her level of control. These things apply to people who are well controlled. So if the patient is super sensitive आपके ख्याल से, तो आप 50% से कम इंसुलिन दे सकते हैं. If the patient is very resistant, उसकी शुगर हमेशा ही 250-300 रहती है, so you may not just reduce by 50%, you may reduce by only 25%. So there can be a change in this depending on what kind of patient is coming in for surgery. So as I said, for steroid use के अंदर cover करने के लिए short intermediate acting steroids such as prednisolone के अंदर NPH plus correctional scale with short acting insulin, longer acting steroids के साथ basal plus correctional scale. Correctional dose क्या होता है? So the additional doses of rapid acting insulin, rapid acting मतलब Novorapid, Humalog, Epidrag जो तीनों हैं, can be combined with bolus insulin to correct pre-meal hyperglycemia. देखिए, ये concept, and this is for the benefit of the young doctors who are just starting out, they might not understand what I'm saying. एक patient को आपने basal bolus regime पे रखा हुआ है, यानी कि basal dose के तौर पे glargine use कर रहे हैं, and वो हर meal से पहले उसका आपने fixed dose करा हुआ है, let's say 10 units of Novorapid before each meal. Now this is a dosage when हम कहते हैं सब कुछ ठीक है, शुगर प्री मील टारगेट पे आ रही है, आफ्टर मील भी टारगेट पे आ रही है, तो ये regime उसका चल रहा है. However, हमने टारगेट उसका सेट रखा हुआ है less than 140 प्री मील्स, और उसका आ जाता है 180. So now you are starting at a higher point. तो मील कवरेज का जो हम नॉर्मल बोलस लगाते हैं उससे वो करेक्ट होके नॉर्मल लेवल पे नहीं पहुंचेगा, क्योंकि स्टार्टिंग एट अ हायर पॉइंट. तो उसके अंदर नॉर्मल बोलस के साथ साथ एक करेक्शन करने के लिए, उस हाइपरग्लाइसीमिया को करेक्शन करने के लिए एक्स्ट्रा रैपिड एक्टिंग इंसुलिन लगाते हैं. इसको कहते हैं करेक्शन डोज. So correctional insulin may be added at other times as well, even before bed or even in between, as long as the duration between two doses of the boluses is more than 3 hours. और अगर पूरे दिन घड़ी घड़ी करेक्शन की जरूरत पड़ रही है, दैट मीन्स हमारा बेसिक बेसल बेजल बोलस डोजेज रिजीम हमने बनाया, उसके अंदर अपवर्ड एडजस्टमेंट की जरूरत है। और ये करेक्शनल डोज कैसे कैलकुलेट करते हैं, क्या होता है? करेक्शनल डोज ये है कि हाउ मेनी मिलीग्राम्स विल 1 यूनिट ऑफ इंसुलिन शिफ्ट। सो अगर दिस इज फॉर मिलीग्राम्स अबव 140 मिलीग्राम, जो हमारा टारगेट था प्री मील्स का। सो वी नीड एक्स नंबर ऑफ we need 1 unit of insulin for every x milligrams above 140. So आसान है फॉर्मूला, 1800 का एक कांस्टेंट नंबर है, उसको आप टोटल डेली डोज पेशेंट का जो है उससे डिवाइड कर दें, तो रिजल्ट आ जाएगा। सो लेट अस से द पेशेंट्स टोटल डेली डोज इज 36, so 1800 divided by 36 will give you 20. So उसका मतलब ये हो जाएगा फॉर एवरी 1 यूनिट every one unit of insulin will lower blood glucose by 20 milligram. So in other words, अगर 140 जगह 160 है तो उसके अंदर 20 यूनिट्स 1 यूनिट कवर एक्स्ट्रा देना है उसको, एंड अगर 140 की जगह 180 है तो उसको 2 units देना है. So 1800 divided by total daily dose will give you the factor for which will cover the milligrams above 140 or above target. I hope this is clear. So hospitalization patient के अंदर non-insulin therapies, the use of non-insulin therapies in hospitalized patient in the type 2 diabetes is not recommended. Metformin in hospital patient is not allowed due to presence of dehydration, acute kidney injury patient में commonly होता है, therefore metformin is not allowed. Sulfonylureas increase the risk of severe hypoglycemia and not allowed. GLP-1 agonists are not well tolerated, especially with gastrointestinal side effects and nausea and vomiting, therefore not recommended. SGLT2 are not recommended because there's a high risk of euglycemic diabetic ketoacidosis and should be held 3 or 4 days prior to any elective surgery. DPP-4 inhibitors alone or with basal insulin may be a safe and effective choice in non-critically ill patients. In summary, diabetes has become the world's most prevalent metabolic disease, and the prevalence of diabetes in hospitalized setting has been reported to be as high as 22 to 30% of all non-critically ill hospitalized patients. There is an increased risk of adverse outcomes in hospitalized patients with hyperglycemia with or without pre-existing diabetes. Hypoglycemia is common with tight control targets, especially in the non-ICU setting, and increases their CV risk and mortality. The recommendation for glycemic target, therefore, are 140 to 180 milligrams, and insulin treatment in non-ICU setting, including basal bolus and basal plus regimes, are the recommendations. Thank you very much.
So,
Okay.
Dr. Kaleem, can you take over?
No.
I think his internet disconnected, maybe. Yeah, he's back.
Okay, I'm back. Dr. Osama is here.
Thank you so very much, Dr. Zakir, for excellent presentation. Dr. Osama, are you ready? Yeah.
Okay, Assalamu alaikum everybody. I hope everybody is hearing me loud and clear.
Yes.
Okay, let's start presentation. Okay. So basically my job after Dr. Zakir is basically the management of inpatient hyperglycemia regarding the critical ill patients. And my presentation is based on ACE recommendations, and you can see the ACE logo behind the presentation. Majority of slides are actually taken from the ACE Inpatient Resource Center, Glycemic Inpatient Resource Center, and most of the topics are already been covered by Dr. Zakir Naik, which has made my things life much easier. So I'll be touching the critical ill patients and how to manage hyperglycemia in these patients, because most of the time doing inpatient rounds, and especially those working in ICUs and hospital settings, you encounter these patients very frequently. So let's start. You have all read about what Dr. Zakir has basically said regarding the why inpatient glycemic control is necessary, because there is significant morbidity associated with impaired hyperglycemia. So several improvements in mortality and morbidity are there with intensive glycemic management, have been demonstrated in various RCTs and various medical and surgical ICUs. If you improve the glycemic control, that tends to reduce the cost and improve the outcome as well of the patient. And if the hyperglycemia continues uncontrolled, the risk of morbidity and mortality is much higher. And Dr. Zakir already has basically mentioned that as well, especially the various randomized trials. So why? What is the pathophysiology? You all know that when there is hyperglycemia, that because of several reasons like glucocorticoid, dextrose, a lot of stress, catecholamines, cytokines, and TPN, enteral nutrition, unabated or uncontrolled TPN or enteral nutrition, patient already diabetic. All these factors actually lead to hyperglycemia. As a result, hyperglycemia itself is quite toxic and can lead to volume depletion, hypoperfusion, electrolyte loss, acid-base disturbances, along with generation of several toxic chemicals in the body, which also not only lead to sepsis, but also can lead to multi-organ failure and at the end death. So it has been well proven that you need to control high blood sugars in the non-ICU or ICU settings to prevent morbidity and mortality. Well, as the blood sugar goes up, you can see the mortality increase by 2 times or 3 times in the ICU settings. Especially several trials have been done on post-CABG patients. When the blood sugar going higher and higher, you can see the complication of mortality associated with hyperglycemia, especially external wound infection, tend to go much higher with those patients who are actually having severe hyperglycemia. Unfortunately, in our settings in Pakistan, where we work, a lot of time we see cardiac surgeon asking for help after the surgery, not before the surgery, especially in those patients who have a very severe hyperglycemia. And those patients who have become severely ill, they tend to ask for endocrine help regarding the control of blood sugar. Ideally, these patients should be having a good glycemic control before the surgery and during the surgery as well. Even those patients who do not have diabetes, the hyperglycemia tend to cause more morbidity, and the risk is much higher compared to those patients who do not have hyperglycemia. And same is the case seen with diabetes as well. So there are several trials you can see in ICU settings, patient population you can see over here mentioned, and then you can see the risk of mortality, morbidity is much, much higher. So I won't go into detail about each and every trial that has been done previously. Another, you can see in another, if you do a tight glycemic control in several observational and RCTs, ultra-interventional trials, so significant benefit in terms of clinical outcome. You can see reduction in 65% infection, mortality. You can see various studies done on various types of patients in medical ICUs as well as surgical ICUs. But as Dr. Zakir has told you earlier, that when you go for a tight glycemic control, the risk of hypoglycemia is always there. So your job is to avoid hypoglycemia. Why? Because the hypoglycemia itself is a very important risk factor for the complications. A case-controlled study of more than 5,000 medical and surgical critically adult patients found that if the blood sugar goes below 40, that is a severe type 3 hypoglycemia. The risk of death is much higher. The odds ratio is around 2.28. The risk is more or less 3 or 4 times higher. So there should be a balance between hyperglycemia and hypoglycemia, and the recommendation has been told you already. That is what is the target glycemic range you need to keep. So you tend not to overtreat the patient and not tend to undertreat the patient. So there are several trials, all actually suggest that hypoglycemia is also detrimental, especially in those patients who are critically ill. So you need to keep not only control the diabetes, but also monitor their blood sugars very frequently to avoid hypoglycemia, to avoid readings going below a certain range. You can see over here, it's a J type of curve. You can see this area actually is showing hyperglycemia, and this area is showing hypoglycemia. All that actually hypoglycemia is also detrimental, and hyperglycemia is also detrimental. Not only in patients who are diabetic, but also in non-diabetics as well. So AS recommendation, you can already know, Dr. Zakir has told you earlier that the target range is basically 140 to 180 milligram. That is the green light. And ideally, they have suggested to start or consider IV insulin infusion if the readings are above usually 180 in a patient who is a critically ill, basically. And the readings below 140 are the yellow range, and only in some patients, but not in majority of patients. So this is no longer a recommendation for, especially in ICU settings. And the red below 110 usually. Low readings are not recommended. So what are the patient protocols? Usually the insulin infusion is usually recommended, and especially in those patients who are critically ill, subcutaneous insulin can be considered in those patients who are getting stable or able to take orally as well. And later on, you should know how to transition from IV to subcutaneous insulin. And then you already know that how to add a correction insulins and what to manage the hypoglycemic protocols. There are several infusion protocols, and I'm not going to detail of each and every protocol. That is quite time consuming, but just an overview. What are the indication of IV insulin? You all know that DK is one of the indication, hyperosmolar state, especially critical illness, post-cardiac surgeries, MI, cardiogenic shock, patients who are type 1 diabetic, who are NPO, in labor, in delivery, and patients who are having a hyperglycemia because of glucocorticoids, and sometimes after organ transplant, and those patients who are taking TPN as well, that is total parenteral nutrition. IV insulin therapy components are basically the regular insulin. We use regular insulin, and you need to make a drip to yield around 1 unit per ml or a 0.5 unit per ml. Blood sugar monitoring is the second step. If the patient blood sugars are stable, you can monitor every 2 hours. We recommend to start with a 1 hour monitoring. And you all know that if you give a reasonably high dose of insulin via drip, then you need to monitor potassium, because hypoglycemia is not that much uncommon. Bedside monitoring is hallmark of the management of IV insulin. So you need to rely on the capillary point of care testing, but sometimes you need to keep in mind that sometimes gets inaccurate as well, especially in those patients who are having like shock, hypoglycemia, dehydration, or extremes of hematocrits. Sometimes that has been seen over there. So, but in majority of cases, point of care testing is recommended in all patients. There are several insulin protocols. I won't go into detail, but Aga Khan has its own protocol. There's an app of Aga Khan they use actually for IV insulin management, and we have our own protocol. So whatever the protocol you are using, basically the idea behind is to control the blood sugar and avoid fluctuations, basically. There is no comparative studies of insulin protocol, which one is best. That depends on the center and what amount of expertise actually you have, basically. Idea behind to start insulin infusion protocol is to control the diabetes and appropriately avoiding hypoglycemia as well. And the staff who are actually monitoring the blood sugar should know how to manage this protocol as well. This is the usual desired pattern for IV insulin infusion protocol should be adopted. You need to keep the range around 140 to 180 and avoid this undesirable pattern, which we very commonly see in our setup, because most of the patients are put on sliding scale, even in ICU as well. So this is how the sugar goes in these patients. But even you are starting insulin infusion and you don't have an expertise how to use insulin infusion, unfortunately, in our setup, in most of the hospitals, even after insulin infusion, the glycemic control remains the same. Whenever the readings goes normal, and unfortunately, most of the centers stop insulin infusion rather than reducing the dose. And then as a result, vice versa happens. There's peaks and troughs actually start happening, and there is no point of giving insulin in the such patient if you don't have expertise to use insulin. The desired pattern should be this one. So once the patient is stable enough, sepsis is over, and your expertise tell that it's time to shift from IV insulin to subcutaneous insulin, or the patient is going from ICU to a ward setup, the patient is being set up to a high dependency unit from a critical state to high dependency unit. Instead of continuing IV insulin infusion, you can plan to go for a subcutaneous insulin. So you should know how to transit from IV to subcutaneous insulin. At least 2 hours after the first subcutaneous insulin injection is given, you discontinue the insulin. Usually you have an overlap of around half to 1 hour usually. Don't use only basal insulin in patients who have an A1C usually above 8.5%, or using more than 2 oral agents until unless patients taking is NPO. In NPO state, you can continue only basal insulin. Usually we do not recommend to switch the patient on oral agents from IV insulin. All patients from IV insulin should be shifted to subcutaneous insulin, and then after sometimes, if the patient is stable enough, then you can consider you shifting or adding an oral agent as well, especially in the outpatient settings. So what is the protocol over here is to establish a 24-hour insulin requirement and give the 50% as basal and rest 3 parts into bolus basically, depending on the carb the patient is taking. And then monitor the blood sugar 3 times, 4 times daily. And then if needed, you can add a correction bolus with readings above the 140. This is one of the example. This is the patient who actually was on 2 units per hour IV insulin for last 6 hours. So if you calculate over here, 80% of 24-hour urine insulin requirement is around 38 units over here. And basal would be 50% of this 38 unit would be around 19 or 20 units. And bolus would be 3 parts of this 19 units. That would be around 6 to 7 units with each meal. And then you add a correction insulin according to the formula, 1800 or 1700, depending on the sensitivity of the patient. So coming to a second part of the presentation is basically the management of hyperglycemia in special populations, especially 3 topics I'm going to cover. Third one has already been covered by Dr. Zakir. So I've been touching the first 2 topics. Basically, there is the patient who are actually receiving enteral nutrition via the tube feed, and patient who are receiving parenteral nutrition basically. Other aspects of these patients can be patients on insulin pump therapy or patient on organ transplant. That's beyond the scope of this presentation because we don't have any time for, because that's another topic, how to manage patients who are critically ill and who are actually using insulin pump basically. So I'll be touching these 2 parts. Patients who are receiving enteral nutrition. Patient who put on enteral means a short term can be a possibility or a long term, like a short term nasogastric tube, nasoduodenal, nasojejunal tube, or a long term like PEG tube, gastrodigostomy or jejunostomy basically. Usually we start enteral nutrition while you are patients who are at risk of malnutrition or having an oral compromised intake basically. Those patients who cannot tolerate this enteral feed are shifted to parenteral nutrition. And I'm going to discuss about this parenteral management of hyperglycemia in coming slides as well. So how to manage these patients who are actually diabetic, who have hyperglycemia, and who are actually on either NG tubes or a PEG tube basically. What happens basically, there can be a continuous feed or an intermittent delivery of calorie dense nutrition. There are a wide variety of schedule formulas available. The encoding physiology is almost altered in these patients because of sepsis, critical illness. The risk of hyperglycemia is much higher. Ideally, these patients should be on basal insulin, but because of risk of hypoglycemia, why? Because of abrupt discontinuation. We have seen there is abrupt discontinuation of gastric tube feedings by other physicians like tube pulled or a gastric resident, sometimes discontinued, sometimes there is some other problem. So in this case, basal insulin plus correction insulin is maybe an optimal regime in this case. Why enteral nutrition is dangerous? Because this is one of the studies that's been done. Almost 65% patients actually tolerated very well, but these number of patients actually have more than 7 episodes of hyperglycemia in patients who are actually given enteral nutrition. So not necessary that patient is diabetic and there is no there is hyperglycemia, but in non-diabetics there is hyperglycemia also always. There's a chance that patient do develop hyperglycemia that can be a stress hyperglycemia or a new onset of diabetes as well. So what are the recommendations? Recommendations are basically basal insulin can be once or twice daily, usually glargine once daily, NPH twice daily, along with the correction insulin. And correction insulin can be a regular one or a rapid acting one every 6 hours and superimposed by correction insulin as well. That are the two recommendations are usually recommended in patients who are enteral nutrition. There can be two types of enteral nutrition, like continuous enteral nutrition or a cyclical enteral nutrition. In continuous one, usually 40 to 50% of total daily insulin, basal insulin, long acting or intermediate acting insulin once, twice daily, and a short acting insulin, usually 50 to 60% every 6 hourly. So you should monitor the blood sugar every 6 hourly and then add a correction insulin along with the basal insulin, on those patients who are on continuous enteral feed, basically. In a patient who has a cyclical enteral feed, like 6 hourly, 8 hourly, in that case, intermediate acting insulin together with rapid or short acting insulin can be started with the tube feed, and a correction insulin can be a rapid or a short acting insulin every 6 hourly. Correction insulin, you all know that if the range is more than 180, you add a correction insulin. You can use a regular insulin or a rapid acting insulin, whatever your experience is basically. And with each bolus of basically enteral nutrition, you give a rapid or a short acting insulin, depending on the calculation you have made regarding the total daily insulin. Around 50 or 60% divided into 3 or 4 parts, and then give insulin according to that, and then adjust after 24 hours to maintain the readings around 140 to 180. So how do you calculate? Basically, you calculate the total carb calories given as a tube feed, basically. Then assess the blood sugar every 1 hour. If the blood glucose is getting lower than 100, you add a dextrose 5% or 10%. 5% means 50 gram in 100 ml and 100 gram in 100, basically. 5 gram in 100 ml and 10 gram in 100 ml, sorry. And then continue the dextrose according to the action of the insulin, basically. So depending on your dietitian opinion, you need to ask the dietitian how amount of carbs or calories given in that tube feed, and then calculate insulin according to it. Coming to the patients who are actually on parenteral nutrition. Patient who are on PTPN, basically, the risk of hyperglycemia is always there. And as the risk hyperglycemia goes up, there is a mobility goes up and the mortality goes up as well. Even you can see over here, though patients having a close range of around 150, from less than 180 to 120 in one of the study, the risk of mortality is less compared to those patients who have developed hyperglycemia above 180. This is one of the study that is published in Diabetes Care. You can see patients who are giving TPN for 24 hours, patients who are giving TPN for 2 to 10 days. You can see the risk of hyperglycemia is much higher. A patient who are put on 24-hour TPN. And you can see there are different types of studies published in different journals. You can see the hyperglycemia episodes of hyperglycemia mortality. The risk of mortality is much higher. You can see the odds ratio is much higher compared to those who do not have any hyperglycemia. The infection rate, renal failure rates, septicemia rates basically tend to go up, but they are not studied in every study. But one of the studies have mentioned that the infection, complications, sepsis all go up above with TPN as well if the patient develops hyperglycemia. Basically, what is basically TPN is basically as continuous IV delivery of high concentration of dextrose Usually in our setups, 25% dextrose drip is given along with TPN. So since it is given IV, so there is no incretin stimulation of insulin secretion. As a result, there is lack of incretin effect as well in these patients. Hyperglycemia is extremely common, even those patients who are diabetic and non-diabetics as well. And these patients, the ideal strategy is to start the basal insulin, but always the risk of hypoglycemia is there because of abrupt discontinuation of dextrose sometimes, especially technical issues with the line. So you need to keep in mind that you need to monitor these blood sugars very frequently, and then if the patient readings are going below 140, you tend to intervene with dextrose. The recommendations are basically basal once or twice daily along with the correction insulin, and addition of rapid acting insulin every 6 hours along with the correction insulin. That's the usual strategy we follow, that is recommended by ACE as well, regarding the management of these patients who are on parenteral nutrition. Most of the time when we were actually working in our postgraduate times, we used to give put insulin in the drip basically. There can be a pros and cons putting a regular insulin in the drip, especially a dextrose drip, 5% or 10% or 25%. Pros are basically simplifies infusion lines and infusions. Easier if the patient is discharged in TPN. Basically, that is a pro of this scenario, basically, putting insulin in the TPN. The cons are always there, hard to predict insulin requirement. It's very difficult to predict how much insulin you need to put in the drip. Another con is that once insulin is there, you cannot remove it. So recommendation is start IV infusion along with, if the patient is not on IV infusion, then recommendation is this. I've already mentioned that is a basal plus rapid acting every 6 hours if needed, if the readings are above 180, along with correction insulin. So Dr. Zakir has already discussed how to manage the steroids. Steroid hyperglycemia is very common. It's very, very common, even in those patients who are diabetic, in non-diabetics as well. But it's very common in patients who are diabetic. You can see one of the study over here. In patients who are diabetic, the risk of hyperglycemia much, much higher. They are actually counter-regulatory hormones and impairs insulin action. As a result, there is diminished insulin secretion and hyperglycemia. And unfortunately, in our setup, majority of the patients receiving more than 2 days of glucocorticoid therapy or a single dose of more than 40 milligram prednisolone develop hyperglycemia, and they are not called and then not been monitored for hyperglycemia. And they have been monitored for hyperglycemia after sometimes many days. And even I've seen even diabetic patients not been monitored for blood sugars receiving steroids as well. So recommended approach is to monitor the blood sugars, even those who do not have diabetes. And if there is severe hyperglycemia, usually continuous infusion is recommended. Despite the patient is on scheduled basal bolus insulin, still you need to start infusion because of severe hyperglycemia, and then rapidly adjust the insulin infusion to bring the readings in the target range. This is already discussed basically because there are 2 types of steroids which we encounter in our basically hospitalized patients. That is prednisolone and dexamethasone. Prednisolone is usually recommended to give once daily, but a lot of patients have given twice daily. So basal insulin, NPH is recommended because they tend to cause late hyperglycemia, especially late afternoon and in evening. So NPH covers this hyperglycemia very well. But if the patient is taking twice daily prednisolone, you can adjust basal insulin NPH twice daily accordingly. But patients with a longer acting dexamethasones, like long acting insulins, long acting basal insulins are recommended. And those who have a critical illness, insulin is preferred. Recommendations are basically this one. If the patient is already in insulin and started on steroids, basically, you start with the 20 to 40% increase in the insulin dose patient was already taking previously, and then add a correction insulin on top of it, basically. It's sometimes very difficult to predict how much insulin the patient needs, and there is no such recommendation or a formula which tells you how much the patient would need insulin. The idea behind it was to increase the insulin by 20 or 40%, and then after 24 hours or 12 hours, adjust the insulin so that the patient doesn't develop severe hyperglycemia. So that's my last slide. Hyperglycemia is very, very common in our critical ill patients, even those who are diabetics and those who are non-diabetics. And it is associated with adverse clinical outcomes. They've already been well proven, not only in critical ill, but in non-critical ill patients as well. So there's several organizations like ACE, ADA, Endocrine Society, NICE, they all have protocols how to manage inpatient hyperglycemia. But you need to keep in mind how to manage the patients who have an enteral feed or a parenteral nutrition, especially enteral ones who are having strokes, and TPN ones on ICUs and ventilators, and patients on steroids and possible insulin pumps as well. Thank you so much.
I hope the audience was well benefited with the talks by two speakers, very well explained by Dr. Usama Ishtiaq as well as Dr. Zakir Alvi. We are running short of the time, so we will take few questions and then we'll end our session. The first question is for Dr. Usama Ishtiaq. Sir, can we use continuous glucose monitors in the patients on insulin infusion? Dr. Usama, are you listening?
Oh, sorry. Acha. That's a very important question, and because of lack of time, मैं ला नहीं सका slides. CGM currently is not recommended. That's a summary. Why? Because of in critical ill patients, hypoperfusion, dehydration, anemia, and several other factors. Patient on inotropes, the readings are not that much predictable. And recommendation there, if the patient is on CGM, all the readings should be counter-checked by point of care, especially those readings who are actually high or very low. So currently, no recommendations are there in critically ill patient. I'm talking about critically ill ones, basically. If the patient is stable enough, patient doesn't have any hypertension or dehydration, and patient admitted in the hospital, CGM is a good choice and very helpful here.
Okay, sir. There is a question for Sir Dr. Zakir Alvi. If we need to give dextrose saline or dextrose water to the patients where other IV solutions are inappropriate, what to do to control hyperglycemia? Dr. Zakir, I think your mic is muted.
Right. Sorry. So the question is, how do we treat hyperglycemia of our patient on dextrose? Well, it depends on the rate of infusion. Why is the dextrose being given? Is the patient NPO or not? So if I presume this is a patient who is NPO, अगर वो NPO है तो डिपेंड करता है किस वजह से, कि वो इमीडिएट पोस्ट ऑप है, 4 घंटे में खत्म हो जाएगा उसका NPO, या अगले क्रिटिकली इल है, ये अगले अनडिटर्मिन्ड पीरियड ऑफ टाइम तक NPO रहेगा. अब अनडिटर्मिन्ड पीरियड ऑफ टाइम के लिए पेशेंट है, हमें पता नहीं 2 दिन 3 दिन कब तक NPO रहेगा. एंड इफ द पेशेंट इज वेरी सिक, प्रिज्यूमली ऐसा पेशेंट क्रिटिकली इल होगा, उस पेशेंट के से फिर इंसुलिन इन्फ्यूजन is the best way to go forwards. For a short period of time, you can cover it with either an infusion, depending kitna short period hai, kitna dextrose ka infusion rate hai, or you can give just a short acting insulin or rapid acting insulin subcutaneously, small dose.
Okay, so let's move to the next question. Can we give steroids to the patients, diabetic patients who are on oral hypoglycemic agents? So, sir, any of you can give answer.
Of course, दे तो सकते हैं, लेकिन डिपेंड करता है रीजन क्या है देने का. अगर if it's a
this is open question.
Good enough reason, if it's a good enough reason, तो उसको दे देना चाहिए स्टेरॉइड. ऑफ कोर्स जो भी मेडिकल कंडीशन उसको ट्रीट करें, एंड वी cover the consequences by covering the sugars according to the patient's requirement of a type. मोटा है, दुबला है, बूढ़ा है, यंग है, किडनी कैसी, सब चीजें देखते हुए उसका फिर कवरेज होगा. ओरल से भी कवर हो सकता है in certain situations. In other situations उसको इंसुलिन पे डालना पड़ता है.
Well, that depends. अगर वो inpatient है ना, basically patient stable है, then ideal recommendation all patients or admitted basically insulin होती है basically, you all know. ठीक है, अगर पेशेंट बहुत स्टेबल है, इन पेशेंट वर्कअप के लिए एडमिट किया है और सिर्फ मेटफॉर्मिन ले रहा है, एंड आफ्टर वर्कअप फाइंड टू हैव सम डिसऑर्डर दैट नीड्स स्टीरॉइड्स बेसिकली, दैट डिपेंड्स ऑन योर चॉइस बेसिकली. इफ द पेशेंट मोनोथेरेपी पे था, यू कैन शिफ्ट टू ट्रिपल थेरेपी एंड देन सी वेदर इज पेशेंट गेटिंग अ नॉर्मोग्लाइसेमिया और नॉट. अगर पहले से 4 मेडिकेशंस ले रहा है, 3 मेडिकेशन ले रहा है, देन इंसुलिन वुड बी राइट चॉइस.
Absolutely.
Okay, so this is the last question for today's session. If a 60+ female patient has HbA1c 10 on time of the first visit for hysterectomy, what should we start it? Probably this is a question by a gynae colleague. Sir, Dr. Usama, please answer this question.
10 A1C वाले की सर्जरी पोस्टपोन करो, उसे बोलो 2 महीने बाद वापस आए, हिस्टेरेक्टमी को इमरजेंसी नहीं है, ठीक है, और नॉन इमरजेंसी के अंदर ऐसे पेशेंट को पहले ऑप्टिमाइज करा जाए, फिर दोबारा बुलाया जाए. That's my answer.
Actually, the nice recommendations are to keep the A1C at least below 8.5% before the surgery. मेरे ख्याल में AS जो है ना अमेरिकन है, वो 8% कहते हैं. Ideally, this patient have a A1C before surgery should be below 8%. हाँ, और if the patient has 10% A1C, there are 2 scenarios over here ना, जो हम देखते हैं basically. One is the patient possibly needing surgery after 2 weeks. और 2 weeks पहले वो आपको दिखाने आई है, उसका HbA1c around 10% है. In that case, what you can do, you start the patient on insulin if the patient is already in oral hypoglycemics. और 2 weeks तक उसकी रीडिंग्स मतलब subsidized हो जाती है, improve हो जाती है, then you can tell the patient you can go for surgery. If the patient has a lot of time, for example 3 months or 2 months, then you can wait for the A1C to come below at least 8%.
All right, so due to the shortage of time, we cannot take more questions. I would like now to invite our distinguished panelist, Dr. Aisha Sheikh, to present her views on today's session.
Assalamu alaikum.
Walaikum assalam.
Thank you very much, Dr. Osama and Dr. Zakir Alvi, for very comprehensive, very elaborate, and very informative presentations. And as you have already mentioned, that inpatient hyperglycemia management is one aspect where you can actually reduce mortality, reduce morbidity, reduce patients' duration of stay inpatient, and similarly reduce the revisits to the hospital, rehospitalization rates. So that is important. Whenever you have a patient who is admitted, you have to look at the level of care where he is admitted, like non-critical versus critical care, what kind of nutrition the patient will be receiving, what is the illness for which the patient is admitted, what is the his renal function, his or her renal function. And then remember, as both of our distinguished speakers have emphasized, that depending upon the inpatient needs, so the patient's needs would be varying from day to day, maybe from morning till evening. So you have to keep on revisiting the plan, which means that there should be a dedicated inpatient team that is following these patients to get an optimum diabetes control, to improve the outcomes, reduce their mortalities, morbidities, readmissions, reduce hospital stay duration as well. So thank you very much. And just information that all our webinars are actually recorded and are put on Pakistan Endocrine Society's YouTube channel, which is by the name of PES TV, PES TV. And you can, so I can see that few people are asking about DKA management and insulin dosing for DKA. DKA was already discussed in our last webinar. You can access that through the recorded webinar, which is available on PES TV. And this webinar will also be available on PES TV. So thank you very much, everyone. Thank you, Dr. Kaleem Badini, for a wonderful moderation. And thank you, Anas, Atif, and Harun Saab for your continued IT support for our sessions. Thank you very much.
Thank you very much for all the participants and the panelists.
Thank you from my side.
Thank you,
Dr.
Dr. Zakir.
I would request Dr. Azra to please give your comments about today's session
Uh,
before we finish the session.
Yes, thank you so very much, Dr. Kaleem, and the speakers. Both speakers were outstanding in their presentation. And just like to urge everyone that the better the patient is managed before any kind of admission, or the people we see generally in our outpatient clinics, the better they are managed at that stage, it will really help their future management of diabetes, whatever they're admitted with. If their baseline is going to be bad, then of course, then there'll be a definite worsening of the glycemic control when they're admitted. फिर तो हम दे देंगे insulin and we'll be throwing all our weapons at them. But it's better that beforehand they're controlled as much as possible at all times. So thank you very much to all the speakers and Dr. Kaleem. We'll see you again soon with some other webinar. Allah
Thank you,
Hafiz.
and Allah Hafiz.
On the behalf of Pakistan Endocrine Society, I'm grateful to the speakers as well as panelists who took out time from their busy schedules and came here to grace the occasion. I hope this session was beneficial to all attendees. Allah Hafiz. Thank you very much.
Allah Hafiz.
Allah Hafiz. Thank you.